Hi Ninja Nerds, in this video we're going to talk about valvular heart disease. If you like this video, make sure to give it a thumbs up, comment down below, and don't forget to check out our website, ninjanerd.org. That's where you can find notes for this lecture and whiteboard diagrams, as well as notes and diagrams for every lecture that we have up here on YouTube. All right, let's get started. So valvular heart disease, we're going to be talking about specifically the valves within the heart, and we're going to be talking about when the valves cannot perform properly, because we know that valves are meant to allow blood to go through from one place to another and then close off, and to prevent any type of regurgitation or backflow from that blood going through. And we're using specifically the valves within the heart today because that's where, when we have valve diseases within the heart, we can have issues with sufficient blood flow out of the heart. So let's talk about first heart valves. We know that they just open and close as the heart pumps. And we have our four valves. So let's review really quickly what our four valves are and what they all are and where they are. So we have our atrioventricular valves, or AV valves. We have the one that separates our right atrium and our right ventricle, right? And that's our tricuspid. And then we have the one that separates our right ventricle to our pulmonary. That's our first semilunar. That's our pulmonic. And then on this side, we have the left atria and the left ventricle, and that valve that separates them is the mitral. And then we have the left ventricle to the rest of the body through the aorta, so that's our aortic. So these four valves, we remember, we have the atrioventricular and we have the semilunar valves, and they close together. So the tricuspid and the mitral close together, and the semilunar and the pulmonic close together at the same time, I should say. Because if we understand this and we understand when these valves close, these are separate, right? The tricuspid and the mitral valves are separated. They close at the same time, and then the semilunar and pulmonic, the aortic and the pulmonic, our semilunar valves, close together at the same time. But the four valves don't all close at the same time. And that's to help propel all of our blood through our body. So we understand that we have four valves. They have a rhythm. We have our lub-dub, right? We have our lub here and our dub, our semilunar valves closing and our AV valves closing off and on together, but never the same, never all four valves. So this produces that efficient blood flow through the heart. And when we have heart disease, we have valvular heart disease, we have some problem with either the valve opening properly or the valve closing properly. So when we have a valve that doesn't open fully or is not opening the way it should, we call that stenosis, right? So the word stenosis, or when we talk about any type of valve having some type of stenotic, we're talking about this insufficiency to open. And typically they can also be thickened. Okay. And then we also have the problem with closing. So the valves are meant to close, but either they're not meeting up anymore, so they're leaving an opening, or they're having some type of problem just getting to that closed position. And when they can't close, we call that an insufficiency or regurgitation. And these two words in the medical field are synonymous, but not the same. But I want you to understand that when you see them on the NCLEX, they're pretty much talking about the same thing. So let's look at a valve from the side here, and we can see that this valve right here is normal. It's open. This is our opening here, our lumen. We can see this is where all the blood would be. It's flowing through really nicely. Okay, it's going through that valve wide, nice and open. And this one is closed. So this one, as soon as the blood comes, it can't go through. So it just hangs out on this side because it cannot go through this valve. Perfect. The valve is working properly. But then we have a valve over here that is got stenosis. And when we talk about stenosis, remember, talking about the opening, right? So is this valve opening properly? We're going to say no. Why? You can see here, this lumen isn't as big. You can see that the valve is looking stiff. It's looking thicker. Because of that, we're having problems pushing some blood through, right? We're having problems efficiently opening up, and therefore we're having some problems with things flowing by it. So to make it appear better, or to make it make more sense in your mind, I have two vessels drawn here. The one on the left is our nice open valve. And as that blood goes through, it's perfect, it's beautiful. But on this side, we have a valve that is stenotic. or it doesn't want to open as nice. So maybe this one on this side's a little stiffer. This one's kind of opening, but because it's thickened, it's still creating problems. So the blood cannot get through as nicely. And what happens is there's this bouncing around, there's some shuffling of the blood, and we call that a turbulent blood flow. And that's where we get our murmur, right? And for those of you who are like me, who have some problems with picturing fluids going through this, right? I want you to picture instead, this is because I like, I like talking about candy, particularly if you picture something like a Skittle or an M&M, right? If you had a little candy machine here and you had all of these candies falling through, you paid money, you said, cool, I'm going to pay some money, I'm going to get this candy, and these valves on this side opened up and great, all the candy came out. That's what I wanted. That's what I wanted, that candy. But on this side, this valve is stenotic. This valve is having some trouble opening up. So not all of that candy or that blood is going to be able to get through or get out. And that's the problem with it not opening properly. Let's talk about regurgitation, which is our problem with what? Not being able to close completely. So if our valve can't close completely, we're going to have some issues. So we can see here that this valve is open a little bit. Okay. And for now, we're just going to understand the purpose of the valve not opening, and later we're going to talk about how that will affect the heart. But regurgitation, we have a closed valve here, right? This blood is approaching the valve's closed, it can't get through. Same thing is, there's any blood that was here is just continuing on down, right? But this valve is now not closing properly, right? So if you picture this valve didn't quite make it, or the gap is really big, maybe we'll make this a little bigger gap because the valve's having some other issues. And now this blood that has gone through has a chance to also backflow. And again, we have a sound here. We have some type of murmur occurring. Okay. And why does this happen? Why do we have some problems with our valves? There's a couple different things that can occur, or reasons that we can have valve issues. The first is a congenital defect, something from birth, okay? And then unfortunately that can lead up to actually affecting all four valves. We can also have something else that's acquired, and with the acquired problems, we can get them broken into three different categories. The first is a degenerative, which means that it's over time, there's been a lot of mechanical stress, a lot of stress on those valves, stress on the heart, and it has degenerated over time, or we're having some issues with it now. It can also be rheumatic, which means there's some type of fibrotic or calcification change, which is creating an issue with the valve being able to function properly. And the last is infective. Any type of infectious organism, something like streptococcal, if you have a sore throat that doesn't get treated correctly or over time, it can actually create the infectious organism, can get into the heart, cause endocarditis, and you can get problems with your valve. So let's talk about some problems that the heart and the patient can experience if some of these valves aren't working properly. So now that we understand valvular heart disease, we understand the movement of valves being either stenotic, which are being stiff, or having trouble with regurgitation where they're not closing properly, so they're not quite meeting the position they need to. Let's talk about the heart and get a little picture of how this causes issues within the body and how the patient may experience those symptoms. So let's back it up a little bit and look at this heart. Reorient. We have our right atrium and our right ventricle, our left atrium and our left ventricle. And you're going to see here that I've mostly stuck to the aortic and the mitral valve. That's because the NCLEX does like to hit on these two valves more often than not, and they also like to hit on left-sided heart failure more often than not. And we know that left-sided heart failure is more predominant. It can cause right-sided heart failure. So I want you to understand that there are stenosis and regurgitation for all four valves in the heart, but for the purpose of getting NCLEX questions right and understanding, I think the left-sided heart failure or the left-sided valves produce that picture for us so we can understand what's going on with valves and how that can affect our patient. So first, let's look at our aortic stenosis. So we know that the word Stenosis means stiff, right? And we know that our aortic valve is here. It is located our left ventricle, and it's going to go out through the aorta into our systemic circuit. So let's understand what's going on here. We have the left ventricle. The left ventricle squeezes. As it squeezes, that pushes blood out through the aorta, right? So that valve, the aortic valve, is opening and closing. So as that left ventricle squeezes and that valve opens, blood's pushed out through the heart, through the rest of the systemic circuit, and then the valve closes. But if the valve is stenotic, right, or it's stiff, and it doesn't open the way it should, right? So instead of us having a nice clear opening, now we're going to have problems. We're going to have some stenosis. And we have this stenosis, that blood, when it gets ejected out, it doesn't flow or it doesn't get all that it needs to get out of the left ventricle. So for me, what I like to do is I like to think of, I can't really picture blood like a liquid. It's kind of hard for my brain to understand that, but if I make the liquid some type of solid and give it a number, it makes more sense to me. So the left ventricle, if we think in our heads, maybe there's like, I always think Skittles or M&Ms. If there's 10 pieces of candy in the left ventricle that need to get out, the left ventricle is going to squeeze. Those 10 little pieces of candy are going to go out the aorta. Great, the valve's working perfectly. The left ventricle got out what it needed to get out. But now our valve is stenotic, and instead of our ventricle able to get 10 out, it's only able to get 9 out. So what that means is we have 1 extra left over, right? We're not getting everything out we need to. Then we have 10 more come in from the left atria into the left ventricle, so now we're at the number 11. It pushes that out, but again, it leaves 1 behind. And it keeps doing that. It keeps leaving behind blood. And over time, this ventricle is getting full. What does a ventricle need to do? Because it's getting full, it needs to stretch or it needs to get bigger. And when it does this, it creates what we call left ventricular enlargement. All right, so we have problems with our left ventricle getting able to get that blood out because of this valve being stenotic. It's not opening properly, it's not letting that volume out, and therefore it's creating a stretch or an enlargement of our left ventricle. So now let's look at regurgitation. So instead of now having problems with the valve opening properly, we're having problems with the valve closing properly. And when we have problems with the valve closing, we're going to have problems with what? So this valve isn't meeting quite the way it needs to right in the middle. It's leaving a little opening. The left ventricle is ejecting this blood out through the aorta, but this valve didn't quite close all the way. Because it didn't quite close all the way, some of this blood is able to trickle back in. If it trickles back in, we're allowing for backflow from blood from the aorta to the left ventricle. Okay? Does that make sense? Let's move on to the mitral valve. The mitral valve, you're going to see here, I drew it because the mitral valve, remember, is a bicuspid valve, or it only has 2 leaflets. It doesn't have 3 like all the other valves in the heart. And the mitral valve is the valve located between our left atria and our left ventricle. So we're going to be looking at it right here. And we're going to talk about it being stenotic. So we know that the mitral valve is what? It's stiff. If it's stiff, it's thicker, and it's not opening properly. So this is the one that you can think about again with the candy, right? If it's not opening properly, it's not opening and allowing all of that blood to go from the left atria to the left ventricle. Instead, it's allowing some in, but then some of it kind of has to hang out. So what happens with this? We get left atrial enlargement. Okay, does that make sense? And we have the left atrial enlargement. You can understand how this might also be our issue with left-sided heart failure, because our atria now is going to have trouble and it's going to have to expand and get bigger here. And if it starts stretching, it's going to have less tone. It's going to have less ability to squeeze. The last thing is the mitral regurgitation. Mitral regurgitation means it's what? It's not closing properly. And this, if it's not closing properly, let's get these arrows out of here. If it's not closing properly, say it's trying to close and it almost did, but there's an opening there. And as it pushes blood into here, right, the blood is sitting here. The left ventricle now wants to push blood out the aorta. But this valve didn't close properly. So as that left ventricle squeezes, some goes through the aorta, some goes bloop, and we get some backflow or regurgitation from the left ventricle to the left atrium. And what I want you to get from this is that there is just a numerous amounts of issues with the blood flow through the heart. And we know that blood is the thing that in our body that's able to give us all of our nutrients, our oxygen. And if it's not delivering those properly because it's not moving through the heart properly, we're going to have some issues. So let's quick talk about some risk factors that people have in order to develop some heart failure or heart valve disease. And what we're looking at here is hypertension. Remember I talked about that in the beginning with the mechanical stress over time. If you have hypertension and it's causing all that pressure within the heart, pressure on those valves, we can have some issues with the valves over time. Also rheumatic fever. Rheumatic fever you can get, and it'll cause some inflammation within the heart. And when you have inflammation within the heart, especially within the endothelium or the endocarditis, which is inflammation of the inner lining here, it can affect the valves working properly, and they can become stenotic. What else is going on? We have congenital malformation. If you're born with any type of malformation within the heart, that can be a risk factor for you. Infective endocarditis, like I just said before, any type of infectious organism that can get into the heart and cause that inflammation. It'll cause some issues with the valve. And the last is Marfan syndrome. Marfan syndrome is a connective tissue disorder, and we know that our blood vessels and our cardiac system uses connective tissue a lot. So if we have an issue with our connective tissue, we're not going to have proper flow or usage of our heart, and we can cause some issues down the line, especially with our valves. Let's look at a patient here who has possibly some type of heart or valve heart issue. So when we're looking at these symptoms here, we have this gentleman right here, and he's got some issues. When you have problems with blood flow or you have problems with deliverance of nutrients and oxygen, you want to start thinking about how that can be produced in a patient's symptoms. So you might have a patient come in and they're going to say things like, I've been feeling kind of dizzy, or I've been feeling kind of sleepy, or when I go to move around, I'm having some of this chest pain, but I don't really know what it is. I can't really pinpoint it. So you're going to go through your assessment and you're going to, ask them questions. But what symptoms are they going to be complaining about? They could be complaining about dizziness. They could be complaining of fatigue. They could be complaining about being short of breath or just having some dyspnea. Difficulty sometimes, but not always. I can't really pinpoint it. And then they're going to have some type of angina or chest pain. Okay. And what we're looking at here is just a general kind of presentation. You don't know anything about this patient right now other than they've got some of these symptoms. They're just saying, I've been having some dizziness, I'm having fatigue, some shortness of breath, angina. And these are just the general symptoms that don't necessarily point to valvular heart disease, but they also are something that patients who do have valvular heart disease can experience. And I want you to understand that, because on the NCLEX, what the test tries to do is it'll say they're having this symptom and that symptom, and these should be things where you're thinking, well, it could be a problem with the lung, or it could be a problem with the heart, because each patient varies with each case. Some people, they know they have some type of mitral stenosis, but it's not something that needs surgery, or it's not something that they need to do any type of, care for right now. But in some time in the future, we may start to, integrate some type of care, but we're going to keep an eye on you. So this patient comes in, they're saying, you know, some of these things, and you're moving into your assessment mode. You're like, I gotta assess this patient and I gotta figure it out. Is it lung? Is it heart? Is it something else, neuro altogether? I don't know. Because this patient is complaining of a neuro possible problem. It's complaining of a lung problem. It's complaining of a heart problem or a cardiac issue. So we have to make sure we are assessing our patient as well as being able to rule out things that quite possibly could be harmful right then and there, right? We want to make sure that we're not letting our patient die within the next, 20 minutes or 15 minutes. So we're going to assess them. And the first thing we're going to do, besides letting the doc know if they're coming in, they're having this chest pain, is you want to make sure you ask the doc, or the doc will tell you to get an EKG, make sure we're not having any type of MI. And we're also going to listen to the lungs and listen to the heart. And what we're listening for is any type of murmur, right? And we know that murmur means turbulent blood flow. That means that there might be a restriction or a problem with the flow through the valves. And when we listen, you want to make sure that we're listening in our points of auscultation. Remember that we have the aortic valve is the right sternal border, second intercostal space. Pulmonic is the left sternal border, second intercostal space. Tricuspid is our fifth intercostal space, left sternal border. And then the midclavicular line, fifth intercostal space on the left, is our mitral. So we're going to listen to all those and see if we can pinpoint. Maybe I think there's an issue with the tricuspid. Maybe I think there's an issue with the mitral. And this is just for your assessment. You're not diagnosing the patient. Remember, you are the nurse, so you're just making sure you kind of know what's going on with the patient, because if you hear this on the first assessment and then you hear it worse later, then we're going to be like, oh no, something's changing here, doc. You want to also ask your patient if they're having any palpitations. Right? Are they experiencing any type of palpitations? Are they experiencing any type of neck pain? Are they experiencing any type of swelling? Because what are we leaning towards here? We're trying to figure out if this patient is having some type of valvular heart disease, and we can't just necessarily say, oh, you have a murmur, it's a valvular heart disease, and move on. That's not the gold standard, that's not the test. But we want to make sure that we're kind of narrowing it down to say, I got to care for this patient because these are their problems. They are having leg swelling or they are having neck pain. And it's not actually anything to do with the heart. But we don't know that. We're just assessing, we're checking the lungs, we're checking their heart, making sure that we know what's going on as they present themselves now so we can notify changes later. So you did your assessment, you go to the doc and you're like, hey doc, this patient's here, and come in and you see them, and they're going to probably go in the same way you are. They got an EKG. They might want an X-ray as well to check out the chest, check out the lungs, check out the heart. And then, them being the smart doctor that they are going to get an echo for our patient. And an echo for our patient is the gold standard to diagnose our valvular heart disease. So they're going to get an echo. They're going to look at the volumes in all the chambers, and they're going to say, yeah, this person's got valvular heart disease, and it's so severe that they're going to need surgery to replace it. So we as nurses are going to not only probably give pre-surgical care, but post-surgical care. So this patient is going to get surgery. They may either get a xenograph, which is another species valve that we put in, a cadaver, which is another human valve that we can place in there, or an autograft, which can be the patient's own valve from another part of the body. And what they need to know right off the bat with education is a couple of things. The most important is that it will be replaced or needs to be replaced in 7 to 10 years, depending on the patient's case and their care for it. And also we want to know if our patient has good compliance with medication, because when these patients do get valves, they're going to need long-term care on some medications. And we need to know, are they even compliant with the ones they're on now, or are we setting them up for any type of other issues down the line? So our patient gets surgery. More common than not, it is open chest, but there are other approaches to replacing the valve. But we're going to assume that they got an open chest surgery, and we need to care for their incision, which is a nice incision down the center here. So we're going to tell them to splint it for comfort, and also make sure that they're keeping that incision safe. And we're also going to give them pain medication. We're also going to put our patient on telemetry. Remember, our patient just had their heart surgery, they had a valve replaced in there, so we want to make sure we're able to keep an eye on the heart, and that way we know that if there's any issues or any changes in the rhythm, we're going to be able to tell the doc and notify and take care of the patient before any other issues come along. We want to also make sure that they are educated on what? What's the scale here for? Weight. Particularly weight gain. We are very keen on weight gain, particularly the red flags that you want to tell your patient are 3 pounds in 1 day or 5 pounds in 1 week. We want to make sure that our patients are weighing themselves the same every day or every other day, or just so that they are able to keep an eye on themselves. Initially, it's going to be a weight check every day, and it's going to be like that for a very long time because we want to make sure that they are taking care of that valve, and that valve is also taking care of them. It's working properly, it's working the way it needs to. So they are going to get daily weights, and they are going to make sure that they haven't gained 3 pounds in 1 day or 5 pounds in 1 week, because what we're looking for is we're looking for any type of fluid overload or insufficiency of that valve. Like I said before, one of the things we're looking at with our patients is we want to make sure that they are not having any problems with medication adherence, because these patients that get valves replaced are going to be on anticoagulants. Okay, and what that means is they are going to be on them for long term. And those anticoagulants are going to help that valve work properly by not maybe overstressing it and helping it do its job. And what we need to do is to teach the patients that they should be avoiding some things that can cause issues with that treatment. Because when we're on anticoagulants, we're going to have to get blood work checked potentially, and we're going to have to make sure we know how to care for ourselves if we are taking some type of anticoagulant. So we want them to make sure they're avoiding NSAIDs and aspirin, right? Those are 2 medications that can affect our blood work for our anticoagulants. We also want to make sure that they're keeping an eye on not taking the over-the-counter ginkgo biloba. Ginkgo biloba is a homeopathic over-the-counter substance that you can take that usually helps with some type of joint pains and things like that, but it's something that can also affect our anticoagulant therapy, and we don't want to do that, right? We are working so hard. We already had heart valve replacement. We also don't want to mess it up just by taking an over-the-counter medication. We also want to make sure we're not putting extra stress on the heart. Remember, that was one of our risk factors as well. So any type of caffeine, you want to limit. Alcohol, you want to limit. And you want to look for over-the-counter medications that possibly have ephedrine or epinephrine in, because those can also affect the function of our heart and put more stress on our valves as well. The patient's also going to need some prophylactic antibiotics. And that's going to be for any type of dental work and sometimes also anything else more invasive. And that is because, remember, our dental work, we have a bacteria, the streptococcal bacteria, that can eventually cause endocarditis, and that's going to cause an issue with our valves. So we want to make sure that we are able to stay on top of getting prophylactic antibiotic treatment before we go in to get any dental work. And the last thing you're going to want to tell them is to report to their healthcare provider any rashes, fever, shortness of breath, and of course that weight gain. Because if any of these things are occurring, along with any other problems like chest pain, we want to make sure that we are telling our doctor right away so we can get in and see them and make sure that things are working properly within the valve and properly within our heart. That way, we're able to hopefully keep that valve in check before we have some other issue where we're going to have to replace that valve sooner than we would want to. All right, Ninja Nerds, in this video, we talked about valvular heart disease. I hope it made sense. Make sure you check out our website, ninjanerd.org, for the notes and illustrations. And as always, until next time.